In 2004, Dr. Paul Ridker was named by Time magazine as one of the 100 most influential people in the world. Now, how does one get considered for a list of the most influential people in the world? Well, for starters, you must do something transformative. Change the world in a way that is likely to have long-term implications. 15 years ago, it was known but often ignored that more than half of the first heart attacks occurred in people with normal cholesterol levels. More than 10 years ago, Dr. Ridker started a series of studies that demonstrated quite convincingly to me that inflammation was a major factor in MIs and strokes. The data even indicated that the risk due to elevated inflammation was at least as great as the risk due to elevated LDL cholesterol. As you might imagine, this revolutionary finding was not welcomed by everyone. But Dr. Ridker met criticism not with argument, but with more and more evidence. In the past 10 years, Dr. Ridker has truly transformed medicine. As a direct result of his determined efforts, elevated inflammation is now recognized as a critical factor in the major chronic diseases of aging. Dr. Ridker is very much aware that periodontitis is the most common chronic inflammatory disease in developed countries and has been an active participant in the dialogue about the role and potential aspects of periodontal disease in cardiovascular disease. I am very pleased to welcome Dr. Paul Ridker as our keynote speaker to open the 95th annual meeting of the American Academy of Periodontology.
What I want to do is to try to answer the question that my wife asked me. She said, "Why are you speaking to the Periodontal Society?" And so the title of this talk is, "Why is your opening speaker a cardiologist?" Is my wife's question to me about what's going on here this evening. But I think you've already heard a bit about why, and I'm going to try to convince you not just that we're partners in this, as has already been suggested, but in fact that this is a critical piece of, I hope, what your practice becomes. But the key issue, I think, for this society is there evidence that individuals identified at increased risk due to inflammation benefit from a therapy they otherwise would not have received? And secondly, is there evidence that if we reduce inflammation per se, could we actually imagine a world where that intervention might lower vascular event rates? Now, I'm a cardiologist, so our favorite mode of attack is through lipid reduction. But we showed years ago, this is data from 1998 and 1999, that when we give these very powerful statin drugs, we not only lower cholesterol, we inhibit inflammation. And on the left-hand side of the slide, we show that the number of heart attacks and strokes we prevent is greater when inflammation is present and we give a statin than when inflammation is absent. And on the right-hand side, we showed that you could lower CRP levels. You could inhibit inflammation with these drugs. So fast forward, what did we do? We said, well, who should we treat? And I want you to hold on to these ideas about who to treat in terms of when we get to periodontal disease. Each of these 4 survival curves is 25% of this audience. Those of you in the red line at the bottom have a high cholesterol and a high CRP. Well, as healthcare providers, hopefully you've seen your internist, hopefully they've screened you for your cholesterol, and hopefully you're probably on diet, exercise, smoking cessation, and probably on a statin. The yellow survival curve in the middle, though, I'm worried about. These are people who have low levels of cholesterol but have the inflammation that your patients have. And they're at higher risk than those in the light blue curve who we're already treating. But because they don't have hyperlipidemia, we don't treat them. So we designed a big clinical trial. It happened to be called Jupiter. It's a multinational, randomized, double-blind, placebo-controlled trial to address whether or not giving a statin to patients with inflammation can prevent vascular events. So we do this study. We recruit almost 18,000 patients worldwide. We put 6,000 women in to this trial. We have a lot of minority patients. We have a lot of smokers and non-smokers, a very cross-sectional survey that's probably extremely similar to who you see in standard practice. Well, this trial reported out last year and was stopped early by its Data Safety Monitoring Board, because when we gave a statin So I'm going to end with a pitch for the cardiovascular community and then a pitch for you. The cardiovascular community has to move forward. In 1961, colleagues just 20 miles west of here in Framingham, Massachusetts, defined older age, male gender, diabetes, hypertension, smoking as major cardiovascular risk factors. 1961. Well, we know this disease is more complicated than that, and we in the cardiovascular community have to move forward beyond these major risk factors to understand what's going on. So I want to leave you with a real challenge then. If this is a difficult issue to hold on to, this notion that maybe there's something fundamental out there that we've missed, then I would argue the reason your opening speaker tonight is a cardiologist is because what I really want you to do is to do something that Bob Genko tried to do several years ago, but the time is right now. Can improved periodontal care reduce cardiovascular risk? We don't know the answer to that. But the biology of this disease makes sense to me as a cardiologist. The idea that improved tooth health, and again, what I mean by that is saving teeth and performing the kinds of things that you as a community can do to reduce the burden of the inflammation in the oral cavity. There's enough biology at this time to say, can a randomized trial be supported by the NIH to actually bring it to a forefront? Is it possible that one of the keys to preventing cardiovascular disease lies right in this society? So my real reason for wanting to be here tonight was to say, I think my group and this group need to think through this process, because a randomized trial taking high-risk patients with periodontal disease, improving it in some, natural history in the others, and if the cardiovascular event rates came down, well, two things would happen. One is we would have done a great thing for society. And the second thing is the controversy about whether or not this has value would be over. And the only way to get there, I think, is through randomized trials. So Dr. Cochran, Dr. Kornman, members of the board, members of society, thank you so much for the opportunity to be here, and welcome to Boston.